We're giving just a few extra minutes for maybe some latecomers to join us. I want to welcome you this morning. My name is Natalie Wright, and I'm a geriatric education specialist with the South Texas Geriatric Education Center at the University of Texas Health Science Center. And I'm very pleased to be one of your sponsors of today's program. And I want to take this opportunity to introduce several other people that are responsible for this program and say a couple of thank yous. The other primary sponsor of today's program is the VA Learning Center. And from the VA, we have Sue Ng, and she has really worked hard on putting this program together. And I've enjoyed the opportunity to work with you and appreciate everything you've done. I want y'all to know that we could not have put this program on for you today of course, without Galen. And although she is not here today, I want to give a special thank you to Beverly Halter, who is their faculty development specialist. Unfortunately, she's on vacation, but she really was very gracious and worked very hard with us on this. And I want to introduce a couple of other members of their staff that joined us this morning that are doing great things to help us out. This is Roy Thurston, and he's our technical expert in helping us out with all the equipment. And then back in the back there, we have Joanna Ellison. And I have to say it's kind of embarrassing because she was here before any of us this morning, putting together your coffee and juice and so forth. So thank you, both of you, for your help. Also, a couple of other sponsors of today's program. We have the National Gerontological Nursing Association. And I do not believe that we have one of their representatives here, but they are one of the sponsors of the program. And also the AACN is a sponsor of the program, and representing AACN is Emily Tanheco. And also, one of your big sponsors today was Health Point. They contributed quite a bit of the money for the lunch that you're going to have this afternoon. And Jennifer Borth is their representative, and I don't believe that she has joined us yet. Okay. And then also we have Covidian Healthcare as a sponsor. Kimberly Stallo is their representative, and I don't believe that she has joined us yet either. No.
We have another Tiffany Evans. Hi, I'm Tiffany. I'm with Covidian as well.
So a round of applause. Okay. And then just a couple of thank yous to some of our volunteers this morning. We have Suzanne Castle and Shelley Foss from the VA. Are they here? Okay. And so, thank you to all those folks. Okay. Before we get started, just a couple of announcements. If everyone could please silence your cell phones and pagers. If they do go off, they are disruptive to other attendees, so we ask that you silence those for us. If you haven't had the opportunity yet, there are refreshments back there towards the kitchen, breakfast tacos and pastries, coffee and so forth, and feel free at any time to go back there and refresh. And then your restrooms are out the door to the right and then to the left. Okay, any questions before we get started? Okay, all right, I know y'all are anxious, and I'm very pleased to introduce to you our first presenter, Dr. Patrick Kimbrell. Dr. Kimbrell presently serves as the Medical Director of Total Wound Specialists and Wound Healing Associates, and he is the Medical Director of the Center for Wound Care at Warm Springs Rehab Hospital here in San Antonio. He is fellowship trained in wound care and hyperbaric medicine. He is also a diplomat of the Board of Certified Wound Specialists and a diplomat of the American Academy of Wound Management, and he is a fellow and board certified by the American Professional Wound Care Association. Dr. Kimbrell's recent positions include Director of Clinical Operations, Fellowship Director and Professor at the Davis Wound Care and Hyperbaric Medicine Division, United States Air Force School of Aerospace Medicine, as well as an Associate Professor in Wound Medicine at the Health Science Center here in San Antonio. He is a graduate of the University of Texas Medical School. He has extensive clinical experience in complicated wound management, hyperbaric, and geriatric medicine. He is published in the field of wound medicine with textbook chapters, one of which is included in your handouts, as well as multiple research references. He is active in several national scientific societies, chairs national committees, and is internationally recognized as an expert in the field of wound management. He is also the past president of the board of the San Antonio chapter of the American Diabetes Association. Dr. Kimbrell is going to give your first two presentations this morning, and his first one, as you can see, is on the essentials of wound management. And so without further ado, please welcome Dr. Kimbrell.
Thank you, Ms. Wright, and I want to thank the Department of Geriatrics as well as VA for inviting me to speak today. One of the nice things about today's conference is that they're actually giving me enough time to cover the topics. A lot of times I'm invited and given a 15-minute block for an hour lecture, and then I feel like I'm always having to rush through things. I'm going to talk about two things today. First is the essentials of wound management, and then I'm going to talk about the most common wound out there worldwide, which is venous stasis ulcers. And so that will be the second talk that we'll give on there. Many of us, as we train, and I'm certainly the same, in the same boat, whenever we were trained, we were given the impression that wound care was knowing what dressing to put on. And that is important. It is important at the end, and we'll talk a little bit about that. But actually, what's more important is knowing what you must do before you ever select a dressing. Okay, that's really managing the wound on there. And I always smile sometimes, and certainly I was taught this way when I see some patient who had once-a-day dressing changes. Their wound is getting worse, and so the response is to go to 3 times a day dressing changes, and that's not ever been shown to significantly alter a problem wound. So we're going to talk about the dressings a little bit, but really this is going to be mainly about managing the wound. And what I'm going to talk about are concepts that you can use to manage any wound. Now I'm going to be talking about problem wounds because those are the ones that most of us see, wounds that are having some problems healing and so forth. But these same concepts can be used with normal patients that have the ability to heal, and will also help them heal in a better fashion, in a more orderly fashion. We're going to talk about the initial evaluation and subsequent follow-ups, and I'm going to pull together some important concepts of wound management. So you're going to see some overlapping, but hopefully by the end it'll all make sense and give you some idea of some of the things we should be thinking about, and give us some consistency in our wound care, whether you're in a center, whether you're a private practice nurse, whatever your center or your setting of practice is. Hopefully this will be helpful for you. Okay. Today, our challenge is to determine what the wound needs. We need to be fairly aggressive in wound management, especially in those patients that have problem wounds or have the potential to lose a limb. We don't want to wait and see for long periods of time, months and months, to see if something works, especially again in our more complex patients. We want to assess the wound fairly quickly. In the first few visits, get the tests done that we need, and hopefully if there's any consults like vascular, we can get those going. I'm going to talk about the essentials of wound management. These are the topics. There's 6, and actually I've added a 7th, but we're going to talk about bacterial burden, perfusion and oxygenation, management of necrotic tissue, management of edema, management of pressure and trauma, and then inflammation. And then the 7th essential is the dressing that we choose. Okay? but that's the last thing that we usually should be thinking about. So let's talk about each one of these essentials. First thing we're going to talk about is bacterial bioburden. Okay. When we look at bacteria in any wound, most of the wounds that we see will at least be contaminated. Okay? We all have bacteria on our skin. When we have an open wound, there's some bacteria that are in that wound. Okay? And that level of just almost kind of a normal skin flora is what we call contaminated. As bacterial burden or the amount of bacteria increases, we start going this way on the curve. And so as bacteria increases and you get a little more bacteria, it'll be called colonized. But here, people are still healing. And then we'll finally get enough bacteria where it is critically colonized, and essentially what we're going to see is the healing may stop. And that's what we call infection. Okay? An infection is when we have enough bacteria in our wound to stop the healing process. Okay. As bacteria or the bacterial bioburden increases in a wound, we start having problems. We will start seeing increased inflammation. Okay. Now, healing, normal healing is an inflammatory process, okay? But if we start getting too many bacteria in the wound, that inflammation will increase and it'll start finally disordering the normal healing process. You'll start getting increases in toxins because these bacteria will secrete various toxins that can inhibit the wound. And we will start seeing increases in normal type of things like MMPs. Have anyone heard the word MMP? Metalloproteinases. That's a lecture in itself, but those are enzymes that our body produces that helps us heal. They will actually, one of the things the enzymes does, just to show you, is it will lyse the pods that attach our epithelial cells, or skin cells, at the edge of the wound, so that those cells can start migrating across the wound bed. So that's one example of what these enzymes do. We have to actually detach epithelial cells so that they can start growing across the wound bed. But as we start getting increased inflammation because of increased bacteria, those MMPs will start increasing too much, and they can start causing destruction of the wound bed. Okay? They're a good thing that if in too high concentrations can start eating up the wound bed because they are enzymes. So that's an example of what happens when bacteria increases. One of the big things that happens is that bacteria are an oxygen sink. Most of the infections we see are going to be from aerobic organisms, organisms that function off of oxygen. And so they have to get oxygen somewhere, and guess where they get it from? The wound bed. Okay? So as the bacteria count increases, there's more and more demand by that bacteria for oxygen from the wound bed, and it can eventually throw the wound bed in a hypoxic situation, which then will stop the healing process. Okay? Few bacteria don't usually do that. A lot of bacteria can, and you can see in patients that already have arterial disease, it will take fewer bacteria to finally throw those wounds into hypoxic state and cause a deterioration of the wound bed. Okay? As bacteria increases, you'll get a disruption of normal clotting mechanism, and that's important for forming the scaffolding for cells to migrate into the wound. It will start disordering white cell function. You'll get less efficient angiogenesis, and essentially you'll start getting deterioration of the wound bed. Okay. If we look at research, they always say, and they teach us in school, that bacteria levels of 10 to the 5th or greater are consistent with an infection. And that's true, but that data is from normal, healthy people. Okay? They actually did it from grafts on healthy people, and they contaminated them, and they found that in a healthy person at around 10 to the 5th bacteria level, wounds stop healing. Okay? So that data is good, but it's for normal, healthy, non-diabetics, non-rheumatoid arthritis, patients that have adequate perfusion. Hopefully most of you will fit this category. 10 to the 5th bacteria would have to be in your wound before you would stop healing. Okay? Okay. In chronic wounds or in patients that have multiple compromising factors, less than 10 to the fifth can stop the healing process. Okay? And we've already talked about some of the things that happen. And in the immunocompromised patient, again, less than 10 to the fifth can cause problems. When we look at the classic signs and symptoms, you all aren't going to miss this. Okay? When a relatively healthy person shows up and you're caring for them, and they have a wound and they have a lot of redness around it, and they're getting fevers, and it's really a warm leg in this case, this is an ankle. There's a lot of swelling and pain, it's draining pus, you're not going to miss that, right? That's pretty classic signs and symptoms. But there's a whole group of patients, and many of the ones that we're treating, that don't give us the classic signs and symptoms. They may just show delayed healing. Some slight change in the wound bed color. It might have been beefy red and healthy looking the week before, and now all of a sudden it's a little paler. And there you're saying, I wonder what's going on. Their granulation tissue, that tissue that you want to grow, will start getting kind of friable and look kind of sickly. They may just have an increase in odor. This is a big one, sudden increase in drainage. Or pain at the wound site, especially in a diabetic. Okay? If you have a diabetic who is neuropathic, let's say in their foot, because that's what the majority of wounds are seen in diabetics, and they usually don't feel too much, and suddenly they complain of increased pain, that may be a sign that the bioburden is going up and they may be becoming infected. So these are the signs that those of us that are taking care of some of the more complex patients need to understand. It can be much more subtle than just that, draining pus and warm and so forth. Okay. So the traditional signs and symptoms may not be present in the chronic or compromised patient. Increasing pain and some little insidious wound breakdown may be sufficient for us to be suspicious that the bioburden is increasing, that maybe they're becoming infected. Okay. So how do we reduce bacteria, bioburden? Okay. There's a lot of different interventions that we can do. We can debride a wound. We can cleanse a wound. And I put here, avoid use of antiseptics, routine use. Okay. Today, we've historically used a lot of toxins in wounds. And when we discovered those toxins were causing problems, we kind of went to the other extreme and started talking about never use toxins. I don't want you to ever say that I told you that, okay? You should use toxins appropriately, okay? And we'll talk about that here in a minute. Okay, so most of the wounds you're going to see that are not infected will be colonized. They have normal levels of bacteria, okay, colonized wounds. When you have a wound that is okay, doesn't look infected, but you know that it's a chronic wound and that it does have some bacteria, you're going to do routine wound cleansing and exudate management. Okay. You'll do thorough cleansing. Sometimes you'll lavage it with saline. You can lavage it with different mild toxins. Sometimes that will be the order on there. You may do some debridement. But most of the time with just colonized wounds, it's going to be routine exudate management, picking a dressing that controls the exudate, doing routine, maybe saline or soap and water rinse, and then redress it. As you start getting more bacteria, okay, and you get to the point where you are critically colonized, and critically colonized means you're starting to see negative effects on the wound heal. Okay? Hopefully it's early, you've caught it early. Then you're going to have to do more thorough cleaning. And we'll talk about this. We're going to talk a little bit in a minute about debridement. You may need to debride the wound. Okay? And this is a time we may consider topical antibiotics. Silvers have become very popular. Okay? But don't use a silver unless there's a problem with increasing bioburden. Everyone's been telling you that silvers have no resistance. There's no bacteria that's resistant. Guess what? We're starting to see resistance, okay? Because we're using it so frequently. We knew that this was possible because when this craze first started, people who looked at silvers found that there were evidence of silver resistance, and where they found it was in photographic labs. they use silver in photographic labs for developing pictures. And so what they did was they went to the sink of these photographic labs where the silver was poured out, and they looked into the drain and cultured that, and they found silver-resistant organisms. So those of us that knew about that realized that if you've got enough silver exposed to bacteria, it is possible for them to become resistant. Okay? There's 9 different ways silver kills, and so it takes a while for resistance to form. Okay? But we're starting to see that. So be careful. Use silvers wisely. They're very good, but you don't want to use them just willy-nilly, because then we'll start having problems with that. Okay? You can use things like slow-release codexamer iodines. Now, iodine is something that if you pour on the wound directly is going to cause problems. If you use it in a slow-release form, it can decrease bacteria count and have low effects, low negative effects on the healing process. So those can be used. But straight iodine, we don't use in open wounds. Okay? There's other things that can be used topically. We often will use Bactroban, bacitracin, and so forth. Once in a while, triple antibiotics, but you don't want to use triple antibiotics or neosporin or something too long, because patients can become sensitized to it. Okay? And we're going to do exudate management, which usually means we're cleaning and then we're picking, if it's a highly exudated wound, we're picking a dressing that will absorb that. Okay? These patients, as you start getting suspicious that they're becoming critically colonized, and that's the wound bed is starting to deteriorate, you're going to usually need to be on either oral or IV antibiotics. And if you catch it early, we can put them on oral antibiotics and knock that out right away. Okay? Stick with simple things at first. Cipro. Okay? You don't have to go to the $1 million one. Get a culture, and then you can become more specific. Okay. So that's the first thing that we should think about when we're looking at a wound, is what is the bacterial bioburden? Okay. Talked a lot about it. Takes you 1 or 2 minutes to do that. Okay. We're just talking a lot about it so that you can learn about it. Next thing that we should be concerned about is what is the perfusion and oxygenation of that wound? Okay. Is it getting oxygen? Of course, oxygen and blood flow are related. So let's talk about the second essential. Give you a little background. Normal tissue oxygen, I'm going to talk about the foot. It's the furthest away from the heart. It's where we see a lot of wounds, lower extremity. So in the foot, if you all have normal perfusion and we did a tissue oxygen measurement, your oxygen should be somewhere between 55 and 85 millimeters of oxygen pressure. Okay? It's just pressure of oxygen. It's the way to measure it, put a number on it. Okay? That's normal. Most people run around about 65, something like that. Or you should have an ankle brachial index of 0.9 or greater. So everybody know what an ankle brachial index is? Okay? You're looking at an ankle brachial index, and there is a lot that could be taught. But what you're looking at is a ratio there. The closest place that we can easily get a blood pressure to the heart is where? The arm. Okay? So the arm is fairly close to the blood pressure of the heart. Okay? So you get the blood pressure in the arm, and then on the same side, say it's your left arm, you take the blood pressure in the leg. Okay? And that's going to give you a different pressure. If everything is clear between the heart and the leg, the pressure should be pretty close to the arm, right? So you put that ratio together, like let's say the pressure in the arm is 120 and the pressure in the leg is 119. It's essentially an ankle brachial index of 1, right? That's normal. 0.9, actually 1.1 is normal. As you start getting blockages to the vessels from the heart to the leg, the pressure is going to drop. Okay. And so that top number, which is the leg one, when you put it in a ratio, is going to get smaller and smaller and smaller. So as you start getting lower ankle brachial indices, that means that you have less pressure in the leg as compared to the arm. The arm is supposed to be the closest we can get is central pressure. So you have dropped your pressure. So it's a good screening test of what is going on in the patient's vascular system. Okay? So healing is maintained to 40 millimeters or an ankle brachial index of 0.7. That tells you that all of us are born with excess perfusion. We have more perfusion than we need in our extremities. I guess God did that because he knows we lose some of that as we age. Okay? So we start out with more than we need. And so, although this is normal, we can have some arterial sclerosis, some decrease in our perfusion, and still heal. So we can heal down to 40 millimeters mercury oxygen pressure or an ankle brachial index of 0.7. Okay? So it's 30% loss in perfusion, but we're still able to heal. When healing is compromised is when we drop our oxygen pressure to less than 40 millimeters of mercury, which usually correlates with 0.6 or less ankle brachial index. Okay, so as we get below 0.7, we start worrying about a perfusion problem. Blood flow may not be adequate. Okay? Questions on this? What happens when we start losing blood flow? Well, oxygen is important for cellular function, so we start getting dysfunction in the cells. White blood cells, which are important in cleaning up a wound, start to function poorly. Okay? So we start losing our normal white blood cell or could become immunocompromised. Collagen, which is made by the fibroblasts, don't have enough oxygen to make collagen because collagen is a process where you hydroxylate different proteins, proline and lysine being the two main ones, and we bind them together to start making collagen strands. So as you drop your oxygen level, you'll finally get to a point where the fibroblasts can't make good collagen. As the cells in the wound bed become more and more hypoxic, they will start leaking because we need oxygen to maintain the cell wall and the transport of nutrients and so forth at the cell membrane, cell walls and plant cell membrane. And so as we drop the oxygen level, eventually that cell membrane will quit functioning and you'll start having deterioration of the cells. And that's what we see, or you'll see when you see your patients as dead tissue starting to form. Necrosis could be black, could be different colors, depending on what type of tissue is necrosing. Okay, and then eventually you can get cell death. So, as you become more and more hypoxic, cells will start dysfunctioning. And we see that clinically as just the formation of dead tissue, necrotic tissue. Okay. Those of us that manage these patients, probably the easiest thing to learn to do is an ankle brachial index. That will give you a good screening test to determine whether you need to be worried about perfusion deficits in these patients. These are other things that can be done, segmental pressures. In our center, we do a lot of transcutaneous oximetry testing to look at oxygen. And then if suspicious that oxygen or perfusion is part of the problem, then once we get some data from one or more of these tests, we may send them for vascular testing to the vascular surgeon, or we may order some of the tests ourselves. So, and I know different people in the audience have different ability to do this, but it's important to understand what direction you need to be heading, no matter what level of caretaker you are. Okay, what can we do to improve oxygen? Okay. Well, remember the very first essential was bioburden, and remember I told you that as bacteria increases, it reduces oxygen. So hopefully we've already identified any problems with infection or increasing bioburden, and we're reducing that bioburden, right? We're using maybe some simple toxins for a short period of time. Once the bacteria bioburden is controlled, we switch to non-toxic things in the wound bed, right? We're going to debride necrotic tissue, and I'm going to talk about that specifically, I think, in the next essential. That will actually increase oxygen because necrotic tissue is an oxygen sink. We're going to reduce edema, and in some cases we may need to send the patient to be evaluated for revascularization. Not everybody needs to be revascularized, but some will. Okay. again, as I talk about each of the other ones, they're going to overlap. So we talked about necrotic tissue. If you debride necrotic tissue, it improves your oxygen. So that's what we're going to talk about next. So we've looked at bioburden. We've looked at perfusion and oxygenation, and 3 minutes has passed in the evaluation of your wound patient. These are just things that, as you become better and better with managing wounds, they'll just become natural and you'll be looking for these problems. Necrotic tissue, that's the third thing that we should be managing. Okay, dead tissue, necrotic tissue is a foreign body. Once our tissue dies, the body no longer recognizes it as part of itself. And I know those of you who've been taught about foreign bodies know that if you get a sticker in your arm, it's a foreign body and it will cause an inflammatory reaction. Well, dead tissue causes an inflammatory reaction too, because the body no longer recognizes it. So here's a necrotic ankle. You'll start seeing excessive inflammation because of this dead tissue. The dead tissue will lower the oxygen. Not exactly sure why, but we know that when we do transcutaneous oximetry testing on a wound with dead tissue, and then we debride that tissue out and redo the test, the oxygen level will go up. So having dead tissue in a wound lowers the oxygen level. And so that's something that we need to always consider is do we need to start taking that dead tissue out? And the answer is going to be yes, but we'll talk about that in a minute. And dead tissue is a nidus for infection. In fact, any foreign body is a nidus for an infection. You've probably been taught that if you have a foreign body, you can't get rid of the infection until you pull the foreign body out, right? Same with necrotic tissue. It is a nidus for infection. Now let's talk about that because it's important for you to understand. Let's say you have a wound and it's critically colonized, so there's lots of bacteria. It's starting to inhibit healing. And you also have an area of necrotic tissue. Now remember, we learned that we should put them on antibiotics. So you put them on an oral antibiotic. The antibiotic level goes up. Let's say it's Septra. It starts killing the bacteria. That's good. There'll be a few bacteria that when you take your dose of Septra and the Septra is high in your bloodstream, there's a few bacteria that are going to run here at this edge between the viable tissue and the necrotic tissue. It's going to hide there. Because that necrotic tissue doesn't have a blood supply, right? The antibiotic level is low. And then when you, in between doses, it'll go out into the tissue and feed a little bit. You take your next dose of Bactrim, and a few bacteria hide along the edge of that necrotic tissue. And so that is why we think that necrotic tissue is a nidus for infection. It gives a non-vascularized area for bacteria to hide. So if you don't also manage the necrotic tissue, you finish your course of antibiotics, everything looks good, and 4 or 5 days later, the wound looks infected again. Because now this bacteria said, yay, there's no more antibiotic, I'm going to go out there and start multiplying. And then it'll increase to that critical level and start causing an infection again. So we need to eventually get the necrotic tissue out, okay, because it's a nidus for infection. It delays and inhibits formation of granulation tissue and epithelium. You will not get live tissue growing over dead tissue. So eventually you're going to have to get that out. I put this kind of in the area of dead tissue, wound exudate and slough, because it's a non-viable substance that will inhibit healing. So I just kind of threw it in with the dead tissue, the necrotic tissue area. Chronic wounds often will have exudate and slough. They can have it for many reasons. Part of it may be because the bacteria levels going up. A lot of times what happens is you no longer have skin here, and the proteins of the plasma start leaking out, and they'll coagulate and cause this yellow proteinaceous slough. But that combination of slough, coagulated proteins, perhaps some bacterial enzymes and so forth, has a negative effect on wounds. It can have different enzymes can form that can destroy healing tissue. And so we want to manage the exudate and slough and reduce it so that you will reduce its negative effect on wound healing. And so it is non-viable type of stuff because it's coagulated proteins, things that aren't alive anymore. And so I put it here. And sometimes we'll be doing some debridement or maybe some other things that we'll do. Okay. Debridement. Debridement, that's one of the ways that we can get rid of necrotic tissue, okay? There's no universal agreement on what technique to use to debride, how often you need to debride, and how much tissue we need to remove. If you look at the literature, there's no agreement on that. There's little factual evidence in the literature to answer any of these questions. But we know that debriding wounds does seem to have a positive effect in the ability to heal. We know from history and from our experience that it seems to enhance our ability to assess the wound because we can see what's under the dead tissue. It decreases our potential for infection, and we already understand why that is, because we don't have that nidus for the bacteria to hide at. Taking out the dead tissue decreases inflammation, and we know that excessive inflammation will disorder the healing process. And it improves tissue oxygenation. So we know these things indirectly from there, and so it seems to be reasonable to take out necrotic tissue when the time is right. Okay. So, the effects of debridement, it quickly lowers the bacteria count, takes away an area for the bacteria to hide. It stimulates the release of growth factors from platelets and macrophages. That's a lecture in itself. I do a 1-hour lecture just on that. But when you re-damage the tissue by debriding it, you set off the healing cascade, and one of the early things that happens, you get a release of different factors from platelets and other tissue growth factors that sort of start the healing process off. Okay? And some of these patients that have chronic wounds that have necrotic tissue, we need to re-stimulate them, okay, when we're managing them. Okay? So we're going to be doing all the things that we're going to talk about, and we can re-stimulate by debriding the wound. It converts a chronic wound to an acute wound. Many of these chronic wounds, let's say they've been there for 3 months, diabetic. They've got some necrotic fat. That's necrotic fat that's there. They've been releasing growth factors and things that are supposed to be normal for healing for a while, but that wound's been open for a long time. And let's say in a diabetic, that's a real common scenario. Diabetics usually run around with their sugars higher than normal. Well, in those wounds that are staying open, in this case, because there's necrotic tissue that no one's managed, those high sugars will start binding with the growth factors. Okay? Those growth factors over there trying to look for different cells, receptor sites to plug into to stimulate healing. But that wound's been open for a long time, sugars have been up, and suddenly those growth factors will become glycosylated, and they no longer work. The receptors on the cells waiting for a growth factor to stimulate it will become glycosylated. The sugar will bind to that. And so you go into a chronic situation where now your growth factors are all bound up, your receptors on your cells are all bound up. Now, the industry has spent tons of money to give us things that's supposed to re-stimulate that normal. Okay? And every now and then they do come up with something that is very helpful. The VAC is one of them. The easiest way to re-stimulate this wound is to make it an acute wound again, and that's where debridement comes in. You cut away all that stuff that's been glycosylated, bound, and you re-stimulate the process. But now, hopefully, you're looking at all the other essentials of wound management so that you can now, hopefully, give a better environment for the normal healing process to proceed. Okay? You're going to control bioburden, etc. You can do the things that we're going to talk about. Okay. So is debridement the most important tool in wound care? It is a very important thing. And there was an interesting study that came out, and it had to look at regranites, okay? Platelet-derived growth factor, regranites. And during that study, a piece of information popped out that had nothing to do with regranites, but actually told us something about debridement. Okay. They had, it was a multi-center study, platelet-derived growth factor. There was a group 1 that got platelet-derived growth factor and group 2 that got a placebo. That sounds routine, right? It's kind of the way studies go. When they started analyzing the data, there was an interesting thing that poked out. Let me go back for a second. When the study started, the study said you have to debride the wound initially and then start using either the growth factor or placebo. You didn't know which one it was blinded. What they didn't tell the centers that were doing this was whether they should debride after that. So some centers did nothing but the first debridement. Other centers did a few debridements. And other centers debrided each time they saw the wound. Okay? There's some interesting data that came out that had nothing to do with the growth factor. Okay? Those wounds that debrided 15% of the time had a 20% heal rate. 33% of the time, 50% heal rate. 68% of the time, 50%. And those that had the highest interval debridements of non-viable tissue, as appropriate, you don't debride a totally clean healing wound, but ones that had stuff that needed to be debrided, 83% of those healed, irrespective of whether they had the Granex on it or placebo. And that just sort of said, whoa, we accidentally discovered something. That sequential debridements, when appropriate, correlate with a better success rate, a better healing. So, a little interesting finding by accident, which kind of supports what we've intuitively seen, but now we're starting to get some data out. Okay, what do you debride? Some of the easiest things is slough. Slough is things like protein that's coagulated and so forth. And we'll talk a lot about slough in the venous stasis ulcer. It can be yellow, tan, gray, non-viable stuff. Eschar. Sometimes it is appropriate to debride an eschar, and that's another lecture in itself. But frequently we do, especially in patients that are problem wound patients. Okay? If they're not healing and they haven't healed for weeks or months, they need to see the wound in. Okay? If they're healing well and most other things under control, some can leave an eschar in those patients. But when they have shown to be a non-healing, not responded to sort of the standard wound care and dressings, often we'll remove the eschar because we want to look at the wound depth. Okay. Necrotic tissue, non-viable tissue, definitely, and necrotic fat. Here's a patient with a wound plantar wound. I'll debride this out, and almost always a week later it'll be full of dead fat again. Have you seen that? Okay. That's a good sign. I'm doing all the other things that we're going to talk about, essentials of wound management, and as this wound gets healthier, there's some dead fat right here and here. And when the wound gets healthier, the body now has enough energy, it'll start pushing dead stuff out the hole. Okay? So that can be a good sign. When I clean it, I'm doing all the other things, controlling bioburden, edema, and so forth. Next week, I'll tell the patient, this may be full of fat again, but we'll debride that out, and once the body pushes all the stuff out, from here, and I get it all cleaned out, it'll just start granular. So, necrotic fat's another thing. Now, if you have a patient that's extremely ischemic, remember that was the essential element before, would we debride them? If we debride an ischemic wound, more tissue is just going to die, right? So first we have to do something to increase the perfusion, whether it's get rid of that infection, something like that, depending on what's causing it. And then we can start debriding. Okay. So you can take a patient to the operating room, and we do that with major debridements that we need to do, or things that we can't do. You can do it in a clinic setting if you're set up for that. There are people that will use autolytic or enzymatic debriders. You all know that we're no longer going to have Accuzyme and Anafil. Right? And I think the only one that's going to be left on the market is Santil, starting January 1st, am I right? Okay. So those are other things that can be used in debride. We'll use scalpels, scissors, curettes. Clinic debridement is fast and selective. You can get cultures. I prefer, whenever possible, to get cultures, tissue cultures, or if there's a piece of bone, get a bone culture. We know that interval debridements in diabetic foot ulcers are associated with increased healing rates, and we change a chronic wound to an acute wound and hopefully kick off the healing process, but now we're managing that healing process and hopefully we won't become a chronic wound. Here's an important concept. Here's a wound that came in, and the history was it would heal and break back down again, heal and break back down again. Well, what was really happening was they were callousing, then breaking back down the callousing. Because everyone was scared to do more than just kind of pick right here. Well, this is non-viable. So what we usually do is start shaving that, and if there's good skin under there, you'll shave down to good skin that looks like that. If you start shaving it and there's not good skin, you come and see what the real wound bed is. And now you can start managing that and get it to heal. Okay. There's other mechanical hydrotherapy, irrigation, wet to dry. We don't use whirlpool much anymore. Okay, that was a modality that was very useful when nobody knew too much about wound care. There weren't any wound centers. There weren't people trained extensively in wound management. And you'll still see a little whirlpool done, but actually today's modern wound management is superior to whirlpool, so we should be hopefully instigating good wound management instead of whirlpool. Lots we could talk about still. Edema. 4 minutes have passed in the management of your wound patient. Next thing you want to think about is there an edema problem? Do I have swelling? Edema creates a relative tissue hypoxia. As you start getting fluid between the skin and the arterial blood supply, you're distancing the skin. If you've got a wound on the skin and you've got a lot of fluid in that leg, you're separating the skin further and further away from the arterial blood supply. Guess what? The skin will eventually become hypoxic, even though you may have adequate perfusion. If you can control the edema, it brings the skin back down against the arterial blood supply, and suddenly the skin is being fed oxygen and nutrients again, and may start healing if you're doing everything else correctly. Okay, so edema creates a relative tissue hypoxia. The worse it gets, the more the chance is that you may have a wound that is hypoxic. As your skin becomes hypoxic, it quits functioning. Sebaceous glands quit functioning, so you don't have the protective barrier of our sebaceous substances and our enzymes that normally protect us against bacteria, because now you have a hypoxic skin, and so these processes stop. So that increases our chance of infection. It sensitizes the skin. It makes it easier to break down. Ischemic skin will break down faster than normally perfused skin with the same pressure on it. Okay? So ischemic skin will break at lower pressures than normally perfused skin. And then the other thing it does is, as the skin quits functioning, it loses its immunocompetence, and it will get dermatitis. It will get red and inflamed easy. Because simple things that never caused an inflammatory reaction now will cause a reaction because the skin is hypoxic. Okay? And so now it's lost its ability to not react to the Tide detergent that the clothes are washed in. Suddenly, the Tide detergent is causing a dermatitis because the skin no longer has immunocompetence. Okay? And I'll get a lot of patients that have been treated over and over for quote, cellulitis, and it's really a dermatitis. But you have to be able to sort of sort that out. Okay. Common causes of edema: venostasis and lymphedema we'll talk about next. Paraplegia. Our immobile patients have lost their pump, their muscle pumps in their legs, and they will start swelling. Chronic wounds can become edematous. Post-revascularization, and we'll get edema in diabetic wounds. Post-revascularizations are patients that have been revascularized. If you're running around with an ischemic leg for 6 months, there's hardly any perfusion going into those blood vessels. Suddenly you're revascularizing those blood vessels, see this sudden 10 times increase in blood flow, they're going to leak for a while. And so many of our revascularization patients need to have edema control, or you've now increased the perfusion, but they break down anyway because you didn't control the edema post revas. And many of our diabetic patients will have a little bit of edema, and as we control those things, it can make the difference in pushing them back to the healing process if we're doing all the other things that we've identified as problems when we're managing those. So we'll often use compression therapy, different types of wraps that give gradient compression. Gradient compression, which we'll talk about in the next lecture, but essentially it's a way to wrap that causes a pumping action back towards the heart. Okay? It pushes the swelling back into the veins and the lymphatics and back into the system and gets rid of it in the leg. We'll talk about that in the next lecture. These are things that are used, and I'll talk about them in the next lecture. ACE wraps are the ones that I use as a last resort, because these lose their elasticity very quickly. You've seen them, you put them on, and 2 hours later they look like hell in there, and they're all separated and falling off. It doesn't give good compression. Occasionally I'll have to use that because they won't tolerate anything. But some of these nice wraps, the least expensive would be in a boot with perhaps coating in there. Do not use TET hose for gradient compression. Boy, they're used a lot out there for gradient compression because they're cheap, they're everywhere. They are designed for anti-embolism. They are not designed to reduce edema through gradient. And we'll talk about that next time. So, 5 minutes have passed in the evaluation of your wound. Next thing you want to look at and say, am I getting pressure? Is there pressure part of the problem here? Is there repeated trauma? Okay. Pressure and trauma causes excess inflammation. We know that's bad. It can lead to tissue edema. It can cause ischemia. You got enough pressure. You can have low-level pressure for a long period of time that can eventually cause ischemia, or high-level pressure for a short period of time can cause ischemia. But at any rate, we already know now, and that's why I say these kind of feed on each other, that ischemia is bad, and can eventually lead all these things to tissue death and recurrent breakdown. So here's your sacral, hip ulcers. These are clean. Most of the time you're going to see them all necrotic and foul and stinky and so forth, and you're going to have to try to get them to this state. But pressure and trauma. In the diabetic patients, it's going to be you do your wound care and they put that same old hard shoe on that caused the wound in the first place. Or they put their orthotic little offloader on until they get out of the building, and then they pull it off, put it under their arm, and walk off with their whole hard shoe. Okay? There's a lot of things that can cause pressure trauma. It's especially destructive in the insensate limb. Remember that pain is the thing that helps us protect ourselves. And our diabetics have often will start losing pain, and they can traumatize their foot, usually very severely, and not realize how severe they're traumatizing because they don't have as much pain. Okay. So it's especially destructive in the insensate limb, in the severely disabled, and the paralyzed patient, and the acutely hospitalized patient. Okay. Most pressure wounds will happen in the first 24 to 48 hours of acute hospitalization. They may not show up for a week. But the acute event will often happen in those first 2 days, which is when everyone is sort of thinking about everything else. They're in congestive heart failure, I got to get these medicines on, I've got time to worry about offloading. Well, no, it's the first 24 to 48 hours. It may not show up for 7 days because it'll just be kind of a pale area on their butt or a red area. And then they're out of the ICU, and it's the ward nurse now that's having to say, ooh, the butt's starting to turn black. Okay. So pressure, and it's very important that we offload it. In the wound patient, we should be offloading and protecting. So we should be doing things to offload a place that has pressure problems during the healing process. So if I've got a heel wound and I want to heal it now, maybe it was pressure related, in a diabetic with rheumatoid arthritis, 86 years old. I know y'all have seen that. You got to take the pressure off. Only takes a short period of time to make these wounds, takes weeks and months to heal them, but you've got to take the pressure off. And you'll have to take more pressure off than what you hope that they can stand once you heal them. Okay, so you have to take a lot of pressure off to get them healed. So don't do good wound care and then they're sitting there in a bed with immobile with pressure on their heels, because you'll just be changing dressings forever. So one of the things about pressure-related wounds is you have to relieve the pressure, and then all your other wound care things will start working. There's a lot of things that we'll use. This is a DH walker, diabetic healing walker. There's a wound there. We're offloading it. In our center, we'll use total contact casts when necessary. Lennard splints, different things. Gaymar air boots. There's all kinds of things. Big cheese blocks. You got to figure out what's going to. And then after you heal the wound, you need to offload and protect. Okay? You need to make sure they don't go right back to doing the very same situation that broke them down in the first place. And so we'll make sure that they get into proper orthotic shoes and so forth, and do our best to reduce their risk for future breakdown. 6 minutes have passed in the evaluation of the patient. And now, the last thing you're going to look at is inflammation. Is there excessive inflammation in the wound bed? Inflammation retards healing. Inflammation disorders the healing process. Excessive inflammation, it can cause pain. It can worsen edema. What can cause it? Increased bile burden. Hopefully you've already taken care of that in the first minute that you were evaluating the patient and made a decision. It can be caused by excessive necrotic tissue. Well, hopefully you've already identified that, but here's another chance to identify that if you missed it. It can be caused by a dermatitis. Treatment. If it's bile burden, usually antibiotics, debridement, topicals. If it's something like a dermatitis, we may, for a short period of time, put a topical steroid and give an oral steroid. But we should be controlling the things that led them to the dermatitis. It may just be that they have venostasis and they have a venous dermatitis. And now you're treating the edema of venostasis. You'll temporarily use Floderm to calm down the dermatitis, but the thing that's really resolving it is that you're controlling the edema. You're returning normal immunocompetence to the skin. And so the dermatitis will resolve. Okay, so those are the essentials of wound management. And then you say, what dressing do I want to maintain the things and decisions I've just made? Okay. So you can see that wound care really is managing the wound. The dressing is the last choice. And it's to maintain the milieu that you feel is important. Okay? There's now over 7,000 wound care products. Okay? 7,000. You're not going to know them all. Are all these things important? Yes. But by intervening with the essentials, you start getting the patient going positive, because you're not going to change their diabetes control, and they've been out of control for 20 years. You're not going to suddenly be the miracle worker that brings them in control when 10 other people, providers in the past. But if you start improving the wound, now you're not in danger of losing the limb, and now you can work on the diabetes. You can look if you think there's a cancer related here. Okay? If there's social issues, they live in a place with a dirt floor, chickens running around, pecking at their dressing. You want to eventually be comfortable with these concepts. Questions? And we'll take a little 2-minute stretch break between thoughts. Any questions at all? Wow. Yes, ma'am.
Dr. Kimbrell, I'd like to know why Perfusion and Brachial is no longer recommended for wound care, and the Sandhill is.
It's not because I use occasionally Accuzyme, and I like Accuzyme. It's not because they've been considered bad, and I don't fully understand this myself, but actually they're papain based, and when they were approved years ago, the FDA approved them with the caveat that there must be research to show that papain based enzymatic things are not negative to humans. And the industry made millions of dollars on it and never proved that. So they had years to do it, they did not do it, and now